Assalamualaikum and hi to everyone. This is Dr. Hakima presenting on the new normal medical CME. First of all, I would like to thank Dr. Tan Injan who is helping me with the IT stuff. Today I am presenting on the topics of delirium, care of confused hospitalized older persons. What is delirium? In a simple term, delirium is called acute confusional state. It is a clinical syndrome characterized by disturbed cognitive function, perception or consciousness that has an acute onset and fluctuating course. Delirium is acute reversible change in cognition that usually occurs as a result of multiple factors including medical disorders, adverse drug reactions, drug toxin exposure, substance intoxication or withdrawal, or it could be a combination of multiple factors. It usually develops over hours to a few days and it is reversible, lasting for a week or less, but it can persist for months. Delirium is a medical emergency that requires immediate medical treatment. Prevalence of delirium in older people is very common. More than half of the patients who undergo operation develop delirium post-operatively, and more than 80% of patients in ICU or at the end of life develop delirium. Up to 60% of patients in the nursing home or post-acute care setting have delirium, and around 10 to 30% of all the patients presenting to emergency department with delirium symptoms. Delirium is associated with more hospital-acquired complications where the patient would have urinary incontinence, increased risk of pressure ulcer with higher risk of fall and longer hospitalizations. They would have higher level of dependency after discharge with higher rate of institutionalization, which would impair their quality of life. The mortality rates can go as high as 76% if the delirium is not properly treated, and 1-year mortality rate is around 35 to 40%. And of course, delirium symptoms can cause significant distress to the patient, family members, as well as the healthcare workers. Based on the latest DSM-5 criteria, delirium is a clinical syndrome that consists of disturbance in attention, where the patient has reduced ability to direct, focus, sustain, and shift attention, and the patient has reduced awareness to the surrounding. The disturbance develops over a short period of time, usually hours to days, and it represents a change from the baseline. So it is very important to get proper history from the caregiver to know the baseline function of the patient. The symptom tends to fluctuate during the course of the day, where it gets worse in the evening and at night time. There are additional disturbances in cognitions where it involves the memory deficit, disorientation, language, visual spatial ability, or perception. The disturbance is not better explained by another pre-existing, evolving, or established neurocognitive disorder and does not occur in the context of severely reduced level of arousal such as coma. So we cannot diagnose delirium in a comatose patient. And there is evidence from the history, physical examination, or lab findings that the disturbances is caused by the medical condition, substance intoxication or withdrawal, or due to the medication side effects. There are additional features to help us in the diagnosis of delirium, where the patient would have psychomotor behavioral disturbances such as hypoactivity, hyperactivity, and sleep disturbances, and they would have variable emotional disturbances such as fear, depression, euphoria, or perplexity. It is very important for us clinicians to know the risk factors for delirium so that we can actively prevent and identify patients with delirium. Risk factors can be divided into predisposing factors, where the patient already has the pre-existing conditions, and precipitating factors, where the acute insult while they are hospitalized. Those who have more predisposing factors can develop delirium with just a minor insult, while those who has less predisposing factors might develop delirium with major insults or multiple insults. Based on the image display, those who have high predisposing factor or high vulnerability needs a less insult to cause delirium, while those who has less precipitating factors and has low vulnerability to develop delirium needs a higher insult or multiple insults to cause them to have delirium. So this is a combination of predisposing factors and precipitating factors that can lead to delirium. This is very important during our day-to-day practice so that we can identify patients early when they are admitted to the hospital, where we actively look out for possibility of delirium and prevent development of delirium. This is a very important slide. This slide shows the risk factors for developing delirium. The risk factors for delirium can be divided into predisposing factors and precipitating factors. Predisposing factors is the pre-existing conditions. So those who are old, dementia or has previous delirium, frail, has polypharmacy, has sensory impairment such as visual or hearing impairment, having functional disability or depression has higher risk of developing delirium. Precipitating factors is the insult that occur during the hospitalization, such as malnutrition, drugs that we are prescribed during the hospital stay, use of the catheter such as bladder catheter or intravenous line, infections, stroke, seizure, or any physiological disturbances such as electrolyte derangement, metabolic disturbances, pain, constipation, dehydration, and urinary retention can cause delirium. Change in the environment includes inter or intra-ward move that we are usually do to our patients can cause delirium, and of course any iatrogenic event can precipitate delirium. Most common causes of delirium in old people are pain, infection, constipation, dehydration, medication, and a change in the environment. First thing about drug, if the patient develop delirium in ward, there are a lot of drugs that associated with delirium such as anticholinergic, benzodiazepines, opioids, TCA, our antihistamines, antiparkinsonism, H2 receptor blocker, antibiotic, anticonvulsions, and many other drugs that can cause delirium. You need to review your medication chart every day, especially if they develop delirium in the ward. There are a long list of drugs that can precipitate delirium. Centrally acting agents such as sedation, anticonvulsion, antiparkinsonism can cause delirium. NSAID can precipitate delirium. Antihistamine can cause delirium. H2 blocker, antibiotics, TCA, cardiac medications, and also over-counter or complementary medicines can precipitate delirium. What are the clinical features for delirium? Delirium needs to have few core clinical features. First of all, it needs to be acute in onset. The symptoms usually occur abruptly over hours to days and typically persist days to months, and you need a collateral history from the caregiver to get the history of the onset symptom. The symptoms and the severity also would be fluctuate during the daytime, and there would be presence of lucid interval. So you cannot depend on one point assessment, and you need to actively ask the staff, especially those working in the evening or night shift, because the symptoms typically more severe in the evening or night time. The patient would have inattentions where they are easily distractible and they have difficulty to focus, sustain, and shift attentions during your assessment. The patient also would have altered social behavior where mood or attitude would be present, where there will be presence of fear, paranoia, or anxiety within the patients. The patient would have poor cooperations with altered communications. Their speech would be disorganized, incoherent, with unclear or illogical flow, and the thought process would be slow. And it's quite common for patients with delirium to have delusions or hallucination. There will be an altered level of consciousness where there will be disturbances with the conscious level, with the reduced clarity and awareness on the environment. The sleep pattern will be affected, where typically they will become drowsy and insomnia during daytime. They will have fragmented sleep and reversal in sleep pattern. In the altered activity, for those who have hyperactive delirium, they would have wandering symptoms. For mixed and hypoactivity, usually the patient will become drowsy with reduced activity or appetite. You have to remember that all people can present with atypical presentations, and the only presentation would be delirium. So delirium may be the only finding suggestive of acute illness in older demented patients or older frail patients, and the caregiver must be educated that in any sudden change in the mental functioning is not expected with most progressive dementia, needs a require prompt medical attention. Delirium can be divided into three types: hyperactive delirium, hypoactive delirium, and mixed delirium. Hyperactive delirium is most recognized because the patients would have disturbing symptoms where they presented with restlessness, agitation, or combative behavior. And the least recognized delirium would be the hypoactive delirium, where the patient usually presented with lethargy, sedation, and apathy, and they would carry worse prognosis because of the less recognized. And there is a mixed delirium, where a mixture of symptoms between hyperactive and hypoactive. Diagnosis of delirium is based on the clinical confirmations. Around 70% of cases of delirium was not diagnosed because the clinician failed to recognize delirium. So the clinical confirmations includes any change in the level of consciousness. With patients, you need to assess on the ability of focus, sustain, or shift attention, where you are testing on the attentions of the patients. And when you are making conversation with the patient, you may elicit memory difficulties, disorientation, or speech that is disorganized or incoherent. And when you are in doubt, formal medical status testing, such as brief bedside testing of attention, should be carried out. I will explain this in the later slide. So there are few screening tools that will assist us in the diagnosis of delirium. The commonly used tools is the confusion assessment method, CAM-score. We are using the CAM-score in ISHTAR, and we can use 480. 480 is a brief questionnaire that will allow assessment for the testable patients where cognitive testing or interview is not possible because of the drowsiness of agitations. So first we go into CAM-score. CAM-score is a confusion assessment method. It is a widely used tool which has high sensitivity up to 94% and specificity of more than 90% in delirium detection. If you are familiar with the tools, it can be administered within less than 5 minutes, and it correlates well with the DSM-4 and 5 criteria of delirium. However, CAM-score is only for the detections of the delirium. The tool is not able to assess the severity and less useful to detect the clinical improvements or deteriorations of the patient with delirium. Okay, we go through into CAM-score. CAM-score target on 4 key features. Okay, feature number 1, it should be acute onset of the mental status change of and fluctuating cause. And feature number 2 is presence of inattention. Feature number 3, presence of disorganized thinking. And feature number 4, there is a presence of altered level of consciousness. For mnemonic, you can remember that the CAM-score stands for AIDA, acute onset, inattention, disorganized thinking, and altered level of consciousness. Okay, so for you to diagnose delirium, you need to have feature number 1 and feature number 2. These two features is compulsory to present, and presence of either feature number 3 or feature number 4. So the total score of CAM-score is 4 out of 4. So you can diagnose delirium with the total score of 4 or 3. Okay, if the feature number 1 is present with feature number 3 and feature number 4, so this is not delirium, because feature number 1 and feature number 2 must presence plus feature number 3 or feature number 4. Okay, so how to assess on the acute onset? The assessment on the acute onset is based on your collateral history. You need a collateral history from the caregiver to get the onset of the symptoms. In the assessments of inattention, you can observe during your assessment, where the patient would have easily distractible, they have difficulty in keeping track of what being said. As I said, this is an observations during your assessment. If you are not sure with the observation, you can do simple bedside testing to test on the attention, where you can ask the patient to count months backwards, or you can give a digit span and ask the patient to recall the digit spans. So if they can do, means that they have good attention. If they cannot do properly, then this is suggestive of presence of inattentions. Disorganized thinking is during your assessment. You can see that they would have rambling, incoherent speech. The speech would be unclear, illogical flow, and they will be switching from subject to subject on the conversation. And the feature number 4 is the altered level of consciousness. They could be either drowsy or hyperactive or agitated. Okay, so this is a CAM score. We are using CAM score in HTAR. Okay, 480. 480 is quite simple, where you are testing on the alertness, AMT4, attention, and acute change in the fluctuating cost. So you need to tick whether the alertness is normal, mild sleepiness, or clearly abnormal. So if the clearly abnormal alertness, then you score 4, and you are asking on the AMT4, where you ask the patient to give tell you about their age, date of birth, and what is the place that they are staying at the moment, where means that you are testing whether they really knows that they are in the hospitals or not. So if there is no mistake, it means 0, 1 mistake 1, and if they have 2 mistakes or untestable, they will be scored 2. On the attention part, you need to ask the patient to list the months of the year from the backwards. So if they get 7 months or more correctly, you score 0. But then if they score less than 7 months, or they refuse to start, it will score 1. If it is untestable, where you cannot start at all because they are not answering you, or they are drowsy, then you will score 0. Okay, the acute onset and fluctuating cost, where you need the evidence to suggest that there is a significant change or fluctuation in the alertness, cognitions, or other mental fluctuating arising over the last 2 weeks, and still evidence in the last 24 hours. This is, you need to ask from the, you need the collateral history from the caregiver or from the staff, from the staff nurse that who is taking care of the patients. So the total score would be 14. The score of 4 or above, suggestive of presence of delirium. Okay. So this is the 2 tools that we can use to assess on the delirium. So how do you go into investigation? Okay, the investigations, it depends on the medical conditions that precipitate the delirium. So usually there will be multiple underlying conditions that are found to cause delirium, and your investigation is guided with your history on and physical examination. So if you think that the patient has an infection, so you need to find out where is the source of infections. You need to check on the electrolytes, check into the medication chart, make sure that the blood pressure, the heart rate, the oxygenation is okay, and assess on the pain, because pain also can cause delirium. Okay, you need to think about the possibility of the less common causes of delirium, where you need to check on the hypoxemia, hypercapnia, presence of adrenal insufficiency, which is quite common because of the exogenous steroid, primary CNS infection, where you need to do a lumbar puncture and CT brain. For those patients where we cannot find the cause of delirium, we need to think of possibility of non-convulsive seizure, where we need to send the patient for an EEG to look for possibility of the seizure spike, and also atypical presentations of the paraneoplastic syndrome. Okay, so very important, quite common patients with delirium is because of the medication. I have a referral before where the patient was referred for the delirium. When I go and see the patient was planned to go for CT scan, but then during our assessment on further history, it is very clear that the patient was being prescribed with tramadol for the last 2 days, and since admission the patient became hyperactivity, reversal of sleep pattern, and on further neurologic examination there is no neurological deficit. So think about medications wherever that you are confronting with the patient with delirium. What is the role for the CT scan in delirium patients? CT scan should be used selectively rather than routinely for most patients with delirium. As I can say that most patients of delirium does not need CT scan. However, it is necessary if there is no obvious cause of delirium during your first evaluations. It should be guided by the patient history and findings on the neurological examinations. It is not indicated if you can find an obvious treatable medical illness or problems, there is no evidence of trauma, there is no new focal neurological signs, and the patient is arousable and able to follow simple commands. However, you should consider to do a CT scan if the patient does not improve as expected during the management of the delirium. Okay, now let's go into the principles management of delirium. What I can say, the first principle management of delirium is to prevent development of delirium. So you need to avoid factors that known to cause or aggravate delirium when the patient admitted to the hospital. So you need to look actively into the polypharmacy, review the medications, make sure they are not dehydration, try to mobilize the patient as early as possible. If they're having sensory impairments such as visual impairment or hearing impairments, put them on the hearing aids or the sensory aids, and you need to make sure that the sleep cycle is not disrupted. So any older patients admitted to the ward should be assessed for the delirium risk, and the intervention must be put in place for the prevention if you identify the risk, and the identified risk must be communicated to all the persons, to their caregiver, to the family, and also the staff that involved in the care of the patient. In promoting preventive strategy of development delirium in the ward, you need to actively identify the predisposing factors and precipitating factors in patients admitted to the ward. So if you find that your patient is old, age more than 65, they have pre-existing dementia, they have multiple comorbidities, they have previous history of delirium, having visual or sensory impairment, they are having polypharmacy, so you know that this patient is having a high risk of developing delirium. So you actively need to remove the precipitating factor that can cause delirium, such as avoidance using of the physical restraint, remove the unnecessary indwelling catheter, review the medications, remove the unnecessary medicines, make sure that we are not moving the patient frequently, manage their pain, looking for hypoxemia or hypercapnia, make sure that they are well hydrated, and avoidance of the malnutrition. So when you identify the predisposing factor and precipitating factor, you need to prevent the development of delirium by promoting a few of the non-pharmacological management, by promoting healthy rest and normal sleep pattern, mental stimulation, frequent orientation, maintain their healthy vision, healthy hearing, healthy eating, promote early physical activity, make sure that their motions or bowel is moving normally, and promoting good conducive environment. In doing the non-pharmacological treatment of the preventions for the delirium, the risk prevention strategies should be discussed with the patient, the caregiver, and the family members, so that everybody understands what is going on, and we have the same goal for the patients. The risk stratification should be documented in your file, and it should be carried over if the patient transferred to the other ward. And of course, the patient who has higher risk of delirium, they need to have a high you need to be careful, because they have a higher risk of falling in the ward. The most important actions for the management of delirium, if they already sets in, is to identify and to treat the underlying cause. At the same time, you need to provide a supportive and restorative care to prevent further physical and cognitive decline. Where appropriate, when you need to control dangerous and severely disruptive behavior, using low dose short acting pharmacological agent is necessary if the non-pharmacological approach failed. So it needs a multidisciplinary teams, where you cannot work alone in management of the delirium. You need good support from the nurses, allied health, and also the pharmacists in helping us managing delirium patients. So the treatments of the underlying conditions, usually multiple etiology, we should actively identify the causes for the delirium, and we need to treat with the comprehensive intervention. Supportive medical therapy is needed to prevent complications of immobility and confusions, which can lead to higher prevalence of irreversible functional decline. So, how to manage agitations? Period of disruptive and hyperactive behavior would place the patient at high risk for fall, wandering off, or at inadvertently removing the intravenous lines and feeding tubes. So, symptom control occasionally necessary to prevent harm and to allow evaluations and treatments. And of course, the non-pharmacological intervention should be the mainstay of treatment. And if the non-pharmacological intervention is failed, cautious trial of psychotropic medication may be warranted in these circumstances. So there are few circumstances where you can use psychotropic medications. First, if you need to carry out essential investigations and treatments, or if you are preventing patients from endangering themselves or others, and to relieve the distress in highly agitated or hallucinating patient. Now we go into the non-pharmacological treatment. The non-pharmacological treatment is the mainstay of treatment for delirium patients. The evidence-based non-pharmacology intervention should be tailored to the patient's needs and the care setting, and the intervention includes first, providing safe and supportive environment where the patients where the environment should prevent the excessive noise, encourage early mobilization, provide consistent caregiver, decrease or avoid medication administered after the patient's bedtime, consistent care routine, eliminate unnecessary stimuli, use a simple phrases when you are talking to the patient, provide supportive aids such as glasses or hearing aids if they are needed, and of course provide feeding assistance in the event if the patient cannot take proper fluid intake or food intake. Number two is frequent reorientations to the environment. So you need to frequently orientate the patients that during your ward rounds, telling them that they are in the hospitals, and if possible, you need to provide an easy to read clock and calendars in the ward so that they can aware on the surrounding. If necessary, you can ask the caregiver to provide or to bring the familiar pictures of favorite clothing to the ward. At the same time, you need to provide adequate fluid and food intake because the patients tend to have malnutrition and dehydrations because of the delirium. Number four is avoiding use of the physical restraint. Physical restraint is only indicated if medically necessary and other alternatives have failed. You can try chemical sedations rather than physical restraint, because restraint can worsen confusion. It will cause additional medical problems such as pressure injury and other complications of immobility. Number five is monitoring bladder and bowel and bladder patterns, because try to avoid constipations and acute urinary retentions because both can precipitate delirium. Try to avoid indwelling catheter, and if presence of indwelling catheter, remove the indwelling catheter as fast as possible if it is not necessary. So this is the orientation board that we have in 8G. It was stated the day, the date, the month, the year, and where is the place that they are staying in, and whether this is a morning, daytime or night, and daytime or nighttime. So during the round, we will actually ask them to read on the board, so it will help to orientate them, to reorientate them. Close monitoring of the vital signs, including your SpO2 monitoring, your glucose monitoring, because hypoxemia, hypoglycemia, hyperglycemia can cause delirium. And of course, monitoring the lab results, looking for the possibility of the etiology for the delirium. Medication monitoring is a must because a lot of medicines can trigger delirium, and all the non-essential medication should be discontinued. You need to routinely assess and manage the pain properly, providing good sleep hygiene. Music or pet therapy can help to decrease agitation and aggression in delirium and dementia patients. However, I don't think this music or pet therapy can be done in the hospital. So we are doing a few interventions in preventing and management in the managing of delirium, where we are doing what activities, try to moving them up, early mobilizations, keep to the routine. Caregiver is actively involved with the care of the patients because familiar faces is important in the management of the delirium. And last but not least, educating the family members, where we need to explain and need them to understand on the delirium, the risk factors, and what are the non-pharmacological treatments that needs to be instituted. We need to orientate the patient throughout the day, where the family members can help them with the orientations. They should stay with the patient as much as possible because familiar faces can reduce agitations. They need to bring family item from the home, and they need to notify to the nurses or physicians if they observe any cognitive changes. This video will illustrate you the ideal ward for the delirium patients in the ideal medical setting.
A hospital environment designed to be elder-friendly will reduce and prevent delirium. Some simple changes include large, easy-to-read room numbers and other strategies to help patients find their way around with less confusion. Bathroom mirrors low enough to be seen from a wheelchair encourage self-care and independence. Newspapers, calendars, and clocks help with orientation and engagement in daily life.
Hi, Gord. It's Donna.
I'm your nurse today. Do you remember me?
I've been looking after you all morning.
The most important thing a nurse needs to do when she's calming a delusional patient is to be reassuring and calming.
How are you feeling? Not so good? Take a minute. Wake up.
To provide a restful environment with a minimal of distractions.
It's lunchtime, and we're going to have something to eat.
The person might need to be fed because for the time being they've forgotten how to do that.
We're going to sit you up on the side of the bed.
And most of all, don't argue with their delusions. If they think there's a snake on the foot of the bed, all they really need to know is that you're going to keep them safe and take care of them.
One of the things that we often find with our older adults, if they do become delirious, is they'll pull out their tubes. So we do not use Foley catheters. We avoid them. If a patient cannot void, we will do in and out caths. We try to get them up to a commode at the minimum and get them to void. They empty their bladder. We don't have as many urinary tract infections because the bladder is totally empty. There's not that little residual that's left there. Also, that getting up and down really helps to ambulate the patient, get circulation going, get oxygen to the brain, and keep them orientated. It's also a normal function, so we try to create normal functions. With our intravenous, we often will have an infuser plug put in, so if they do remove it, often it's not the site that we have lost, but just simply the tubing. We also try to get them hydrated quite quickly so we can get rid of that IV.
Now, why don't you take a sip of apple juice while I start to open your containers for you?
Okay.
Pharmacological treatment should be reserved for severe symptoms of delirium, and for your information, there is no medications currently approved in the management of delirium. Few guidelines suggested that the use of pharmacological therapy is only indicated if the behavior is either danger to themselves or the others. And the pharmacological treatments, we are talking about the pharmacological treatments for the agitations of disruptive behavior, is as a last resort in the managing of distressing symptoms of delirium, and if we fail the non-pharmacological approach. So the principles of the pharmacological therapy, it should be considered in the delirious patients with severe behavioral or emotional disturbances, where it would compromise the safety and the safety to the others, and it will hinder the essential of the medical treatments. And the pharmacological treatment should be used only one drug, the starting at the lowest possible dose, and it will be titrated by a small increment if necessary, and if possible for only shortest possible duration. The prescription should be reviewed at least daily, and you need to be cautious with the use of antipsychotic with those who are at risk of hypersensitivity to dopamine blockage, such as Parkinson's disease or patient with dementia of the Lewy body. The use of antipsychotic drugs in delirium patients is only can be used if absolutely indicated, and the use of the antipsychotic is for their anxiolytic property rather than their antipsychotic property in the managing of the distress symptoms. And if it is used, it should be the lowest possible dose and for the shortest possible durations. And the commonly used antipsychotic, we can use the first generations of typical antipsychotic or the second generations of atypical antipsychotic such as risperidone, quetiapine or olanzapine, and have been used clinically to treat agitations in patients with delirium. Benzodiazepine have limited role in the treatment of delirium as it may worsen confusions and cause sedation. The benzodiazepine can be used in the management of alcohol or drug withdrawal or when neuroleptic drugs are contraindicated. ECG should be monitored in those patients with the antipsychotic because antipsychotic can cause a risk of QTc prolongations and torsades de pointes. There is a black box warning by the FDA that the antipsychotic medications such as haloperidol, olanzapine, quetiapine, and risperidone have been associated with an increased risk of cardiovascular event and stroke in older patients with dementia. So when you want to use the antipsychotic in the demented patients in the event of delirium, the written consent should be out in the file so the caregiver would understand the consequences of the use, the possible side effects of the antipsychotic. Physical restraint in dementia and delirium. This is the pictures that I took when the patient on the physical restraint because this patient presented with disruptive behavior pulling out the rice tube. So you can see that they developed the pressure ulcer on the restraint part, and there are a lot more complications of the physical restraint. So it is not advisable in the delirium management as often aggravates the patient's emotional distress and disturbed behavior, and it might worsen the delirium itself. And the restraint should only be used when there is reasonable belief that least restrictive measures have been determined to be ineffective, means that you have tried all the non-pharmacological treatments and the chemical sedation is not suitable or is not working for this patient, then only you can use a physical restraint with frequent monitoring. There are a lot of complications of the physical restraint where the patient can have acute decline in the function because they have been restrained on the bed, high risk of fall, they will develop incontinence, dehydration, risk of pressure ulcer, altered nutrition, injury, psychological distress, and also disorganized behavior. Fall prevention in delirium. Patients with delirium are very prone to falls. There are many cases that patients have inpatient falls because of the delirium. So the fall among the patients with delirium are usually multifactorial and share the many similar risk factors. So fall prevention strategies in the hospitals should be applicable to all patients with the delirium. It should be multifaceted intervention for fall prevention, where the patient needs to have a multidisciplinary team looking actively into routine medication review by avoiding hypnotic or sedative medication, proactive observation and assistance, ensure that there is a walking aids or glasses within the reach, and consider the low beds. The bed is locked and safe for the patients near to the staff nurse counter. Environmental modifications such as proper lighting, remove the clutter, and make sure that they are having a proper footwear. Discharge and follow-up. Effort should be made to prevent readmission through a multidisciplinary approach and individualized discharge care plan. So sometimes delirium may take more than 12 months to resolve, and the complete resolution of delirium should not be the criteria of discharge. If the patient is improving, you are thinking that the patient is improving, however the behavior or the delirium is not fully settled, you can actually discharge the patient, but then they will need a follow-up post-discharge to assess on the memory exaltations. This is to determine whether the delirium really fully recovers or resolves, or this is the new onset for the dementia. In conclusions, delirium is a common clinical condition which is frequently missed by the healthcare workers. Delirium would lead to higher mortality rates, longer hospital stay, poorer functional and cognitive outcomes, and employment of preventive, early identifications and proper management strategies can reduce the risk of delirium among hospitalized patients and promote better outcomes. Okay, just to share with you my experience in Tan Tock Seng Hospital. In Tan Tock Seng Hospital in Singapore, they have a special room that they call a delirium room. So in this room, they have 6 beds with one-to-one nursing care, and the nurses are highly specialized in managing delirium patients. In the delirium room, they would have this orientation board where they would put on the day, the weather, the date of with the calendar, the traditional calendar on board, so that the patient would be feels familiar with the environment, and they would have a very nice pictures to reduce the agitations. And this is the exit door. The exit door is only accessible with the access card, and they put a very nice wallpaper where the delirium patient does not recognize that this is the exit door, and the patient does not know how to go out, and they will just wanders around in the room, and they won't go out and wandering outside the room. Malaysian Society Geriatric of Medicine have actually come out with the delirium position statement, and you can actually download this delirium position statement from the MSGM website. Okay, this is the references that I use for these presentations, and with that, I thank you.